If you don't want to stand up and would like to actually have a seat, we do have the speakers on in the hallway, so you would be able to hear, but it's a personal choice on what it is that you would like to do. So, committee, we're going to open up the hearing on House Bill 2256. We will be limiting the speakers to 3 minutes. At the end of everyone giving their testimony is then when we will go into answers and questions. So, first up, I have Amy Seipel, President of the Kansas Advanced Practical Nurses Association.
Thank you, Madam Chairwoman and honorable committee members. Thank you for your service to our state. My name is Amy Seipel, and I've been serving the primary care needs of older adults in long-term care centers as an APRN for over 20 years. I come today to testify on behalf of House Bill 2256 and to really just explain the essence of this bill. What this bill does: removes the requirement of collaborative practice agreements and written protocol language. This outdated regulation has created barriers to access of care. In today's landscape, it can be very difficult to find a physician who will sign a CPA, and when you do, often exorbitant fees are attached to it. I once worked for a practice in which I never met the physician that we paid to sign our annual collaborative practice agreement. Now, in 23 states, APRNs either don't have CPAs, they've never had it, or they've been removed. And I refer you to the attachment where you can see the outcomes in these states. What this bill also does, it actually has a structured transition to practice of 4,000 hours for new APRN graduates. It requires all APRNs to carry malpractice insurance, join the Healthcare Stabilization Fund, and maintain national certification. Most importantly, this bill keeps the regulation of APRNs solely under the Kansas State Board of Nursing. In every state where APRNs have full practice authority, they are solely under their state boards of nursing. The Federal Trade Commission weighed in on the risk of putting APRNs underneath the Board of Healing Arts, and they said it was inappropriate and constituted a potential restraint of trade. What this bill does not do, it does not change our scope of practice. APRNs will continue to render care in accordance with our education and our certification. And it certainly does not change the essential elements of collaboration. We will continue to collaborate with other healthcare providers and physicians. In fact, it's mandated in our bill, and it's a requirement of APRN professional ethics. Finally, in closing, I just want to say that because our bill, we weren't able to see it before it was thrown in, we have balloon attachments that would conform the bill to our original draft intent. We have,
Amy,
yes.
30 seconds.
Okay, we have worked with Representative John Barker, and Revisor Scott Abbott has the draft amendments attached. Thank you so much for allowing me to testify.
Thank you, Amy. Next, I have Sonya Slaba. Did I pronounce that right? APRN?
Yes.
Welcome.
My name is Sonya. Thank you. My name is Sonya Slaba. I'm an advanced practice registered nurse from Wichita. I hold 3 certifications as an APRN. And let me tell you why I'm here today, because it is definitely not for political reasons. In 2015, my life changed forever when I lost my youngest brother to suicide. After his death, mental health became my family and I's passion. We became involved in every activity which promoted mental health awareness and suicide prevention. I wanted to focus on mental health and provide those services to Wichita. I returned to graduate school and obtained a 3rd degree as a psychiatric mental health nurse practitioner after I discovered mental health services are greatly lacking in Kansas. Through my advocacy work with the Sedgwick County Suicide Prevention Coalition, I found that suicide is the 8th leading cause of death in Kansas. Suicide is the 2nd leading cause of death for ages 10 to 44. My brother fell in this age group. He was 22 years old when he died. These statistics are very personal to me, as my brother's death counted as one of those statistics. We are losing our youth to suicide, partly due to lack of access to care, but with your help, there is an answer. I am part owner of a clinic that provides mental health services in Sedgwick County. Our collaborating physician is 73 years old. The harsh reality is that if you were to stop practicing today for any reason, whether it be retirement or death, our clinic would have to close, leaving all our patients without mental health services and the medication they desperately need. They would have to find those services in an already too congested mental health system because it would take months, if not years, to secure another collaborating physician for our clinic. It took us almost a year to secure the one we have. I also volunteer with the ICT Street Team, which is an organization serving the homeless population in Wichita. This has opened my eyes to mental health and how it afflicts our very own community and most of our homeless population. Even though I'm trained to do so, our ICT Street Team collaborating physician has placed limits on what we can treat. She is not comfortable treating pregnant women, so we cannot offer expectant mothers any type of treatment, for example. I've also volunteered with Via Christi
Sonya?
Medical Mission at Home.
Sonya,
Yes.
30 seconds.
I've also volunteered with the Via Christi Medical Mission at Home, a day of free healthcare for 2 years in a row. I have had different collaborating physicians each year, which I never met. So in total, I have had 4 collaborating physicians in the last 5 years, and I have only met 2 of them. I urge you to support House Bill 2256. Thank you.
Thank you very much, Sonya. Next, I have Marilyn Douglas, an APRN.
Madam Chair and members of the committee, Marilyn Douglas from Garden City. I'm a family nurse practitioner. Thank you for this opportunity. Access to primary care is the main goal of this legislation. Increasing access to care will improve Kansas public health. But let me tell you, we already have good examples that are going on in Kansas. It's the VA system that recognized this benefit. In 2016, a federal ruling from the VA system allowed APRNs to practice without a collaborative practice agreement, or what we call full practice authority. Many of the 87,000 Kansas veterans benefit from APRNs providing care. The VA system also tracked indicators and are proud to report that because of this change, they were able to increase access to care. They were able to decrease their appointment wait times for veterans and decrease delays of care. The Indian Health Service and the military clinics and hospitals are also good examples of where APRNs are working without a collaborative practice agreement requirement. There are over 20 of these clinics across Kansas and 5 hospitals. What's important to note is that each of these APRNs are diagnosing, prescribing, educating, and managing acute and chronic care according to their education and training, and they are regulated by the Board of Nursing, a trustworthy regulatory board. 23 states have already passed this legislation, and what's important to note is that in none of these states, there has not been legislation to edit, reverse, or modify their existing status. And in fact, they have enjoyed benefits, mostly that of an increased APRN workforce. Nebraska is a good example of that. The best statistic I can share with you is that 20 of their counties that were previously designated a provider shortage county can now have a documented APRN providing care. So this is not a new concept.
Marilyn, 30 seconds.
Thank you. Hundreds of studies already confirm that APRNs with full practice authority provide safe and effective health care. They provide equal and better patient outcomes, increased access to care. They utilize preventive care measures, and they decrease unnecessary hospitalizations and ER usage. Please refer to my written testimony for some of those studies. Thank you very much, and I look forward to your questions after everyone has spoken.
All right, thank you, Marilyn. Next, I have Matthew Allen, a private citizen.
Thank you, Chair Landwehr and members of the committee, for the last 13 years, I have served as city manager for the city of Garden City. My professional experience has helped shape my perspective on this issue, but this testimony is my own. I offer for your review the following case study. The city of Garden City employs approximately 370 insurers and averages 900 lives on its health insurance policy at any one time. By 2010, the city had experienced several consecutive years of double-digit percentage increases to health insurance premiums, along with eroding the insurance plan itself. At that point, the city began to explore alternatives to a traditional health benefit. Ultimately, the Garden City Commissioners took the courageous act to lease and remodel a commercial space for an employer-based clinic and enter into agreement with a private health service contractor whose model focused on the use of nurse practitioners. At the time in Garden City, which has a reputation of being a rural regional healthcare center, over 60% of the city workforce did not have a primary care physician. They were undoctored. No family practice clinics in Garden City were taking new patients. The primary care provider for most of the city's public servants and their families was the emergency room. In 2012, the Grow Well Clinic opened and began serving the City of Garden City workforce as an employer-based, single-payer wellness and nursing services clinic. 9 years later, this clinic is still in operation. City health insurance rates are stable and far below industry averages. The total expenses in the city's health insurance fund, which includes both the employer's contribution to health insurance premiums and the cost of operating the clinic, only represents a 3% total increase from 2012 to 2021. That's total increase, not average annual increase. Average annual increase is well below 0.5%. Participation in the clinic is nearly 100%. Satisfaction in every measurable way is above 95%. The cumulative budgetary savings over industry averages during those 9 years exceeds $3 million. And by comparison, we've had some pretty large industrial and commercial projects in Southwest Kansas and in Garden City. The budgetary benefit of the clinic exceeds the benefit of any one of those projects. This case study provides evidence of the transformative impact you can expect from unshackling nurse practitioners to do what they are trained and capable of doing in Kansas.
Matthew, 30 seconds.
Thank you. Especially since there is a shortage of care in most of the state. Oversight and quick access to a medical doctor or diagnostic services are the only two reasons I've been given in the decades since we began looking at this option. And those are simply unfounded. I would encourage you to help Kansas minimize and potentially eliminate its healthcare deserts by removing barriers that limit supply and increase profits for those working at the bottom of their credential and allow nurse practitioners to operate at the top of theirs.
Time.
I look forward to taking your questions.
Thank you, Matthew. Next,
You're
I have Kathy Gordon, an APRN. Welcome to committee, Kathy. Did we just freeze up? No? All right, Kathy? Okay, we'll come back to her. All right, we're going to come back to Kathy because.
Can you hear me now?
Yes, we can.
Yes.
Okay. Woo,
All right, let's go.
technology. Thank you so much, Chairman Landwehr and committee members, for this wonderful opportunity to talk a little bit more about House Bill 2256. I have been a nurse practitioner in Kansas since 1998. While I worked in the emergency department, my eyes were wide open to some of our healthcare needs in Kansas. One of those being how many people use the ER for primary care services, primarily because they couldn't find a primary care provider or they didn't have a medical home established. It didn't work around their work hours. This need for me turned into a vision, and I started a nurse practitioner-based clinic in Johnson County, the county that has per capita more underserved and uninsured people in the state of Kansas. I started that clinic way back in 2000. It's over 20 years old, and it offers primary care services for over 11,000 Kansans right now. We quickly grew out of capacity and expanded into Wyandotte County services, and you might know us as Mercy and Truth Medical Missions. But I can't tell you it was easy. The restrictive burden of ongoing collaborative practice agreements was horrible. I lost sleep at night. I called physicians after hours at 10 p.m. one time asking, could you please cover us because one of our physicians just died? Or we've had the incidences where they were diagnosed with cancer and they no longer wanted to practice or could practice, or they retired. These burdens are constraining to the practice. And what were we going to do? Not open our doors when we're serving so many needy people. So I ask you to consider this as a really good thing for Kansas. Full Practice Authority is not expanding our practice, it's expanding health care to our citizens. Massachusetts has done this. And what I mean by that, it took a pandemic for all of us to look at removing this restriction on an emergency use basis. And Kansas, thank you, legislators, you did that for us. And the Kansas Medical Act provisions, the Emergency Medical Act provisions are doing that now. I ask you to please continue them like Massachusetts. On January 5th, this year, 2021, Massachusetts said, we get it, we need to enact it, and they released and put into law full practice authority for nurse practitioners. I urge you to do the same here in Kansas. Release that burden of practice, open those doors. It will increase our workforce probably by doubling it. Nurse practitioners live in 102 counties in Kansas. Wow,
Kathy,
what can this do?
Kathy, 30 seconds.
Okay, yeah. Thank you so much. I provided a written testimony for all the details of what I'm talking about today, but I'm available for more questions. And I just want to say God bless you all and thank you for your service.
Thank you very much, Kathy. Next, I have Nicole Lavanos. I hope I pronounced that right. Associate Director of Legislative Affairs, National Council of State Boards of Nursing. Are you there, Nicole?
Can you hear me?
There you are, yes.
Oh, so sorry. All right, Madam Chair, you got my name right. Thank you so much.
Okay.
As you've heard today, this issue isn't new. In addition to the 23 states where APRNs practice without these restrictive collaborative agreements every day, APRNs right here in Kansas have been caring for COVID-19 patients without these agreements since May. And that is thanks to the swift action of this legislature in passing House Bill 2016 and Senate Bill 41. Kansas joined 11 other states in removing these barriers during this unprecedented time. So since May, APRNs in Kansas have had flexibility to respond to COVID hotspots, and facilities have been able to recruit these highly skilled practitioners from around the state, but also our surrounding states, without having to find these physician collaborators for each. The swift and smart action increased access to care during an unprecedented time. And while these temporary waivers are in effect, the Kansas Board of Nursing, KSBN, has continued to regulate APRNs. In fact, the Kansas Board of Nursing has been regulating APRNs since the 1970s. Across the country, 47 states regulate APRNs under the Board of Nursing. And in all states that have taken action to remove barriers, such as Kansas seeks to do today, APRNs are regulated solely by the Board of Nursing. It's been mentioned by some, and why I bring it up today, that regulation of APRNs in Kansas should be moved under the Kansas Board of Healing Arts, which is the physician-controlled regulatory body in the state. In addition to the concerns about the unknown effect this would have on APRN practice and patient care in the state, the Federal Trade Commission also weighed in on this specific issue to Leader Hawkins in 2020. The comments attached to my written testimony, but I want to summarize a few key points here. First, the FTC notes that removing collaborative practice agreements will improve access to care, contain healthcare costs, and expand innovation. These are all results they've seen in the other states. Second, they warn that moving APRN regulation under the Kansas Board of Healing Arts would be anti-competitive. And last, warn that this unprecedented move of regulation would discourage new entrants into the profession, deter competition, and suppress innovation in services. Kansas needs more healthcare providers, not less. Kansas needs greater access to services and safe and qualified APRNs, not less.
Nicole, 30 seconds.
Thank you. I would point you to KSBN testimony submitted today that will demonstrate that KSBN are the experts in APRN regulation. They license, discipline, approve programs in the state, and enforce the Nurse Practice Act for all APRNs. The board regulates the current scope of practice for APRNs. That's the same scope of practice that will be in place after House Bill 2256 is enacted into law. 2 APRNs sit on the KSBN, and they have an APRN advisory committee for further expertise.
Nicole, time.
Thank you so much.
Thank you. Next, I have Ginger Breedlove, PhD, founder and principal consultant of Grow Midwives, LLC.
Honorable representatives, thank you for your service, for the ability to present testimony today as a lifelong Kansan, and really for your willingness to listen. As you stated, my name is Dr. Ginger Breedlove, a PhD in nursing and a certified nurse midwife. I'm past president of the National Organization of Nurse Midwives, the American College of Nurse Midwives. I established the KU Graduate Midwifery Education Program and now run the largest national consulting firm for midwives in the United States. I have visited the halls you sit in many times over many decades. I first came and sat in the Senate chamber as an elected girl state representative in high school from Wyandotte County. I've grown up and practiced the majority of my 40-plus year career as a nurse and midwife in the state. I have testified in U.S. Congress to help pass the maternal mortality bill that President Trump signed into law in December of 2018. My husband worked for a time as an attorney at the Kansas Healthcare Stabilization Fund and helped guide adding the CNM to their professional definition for coverage in Kansas. I know the debate over advanced practice nursing history in our state well enough to write a textbook, and I'm sure many of you here today do as well. Instead of reading the email letter I sent each of you last week, sharing the facts that likely replicate many others you're hearing in testimony today, I decided as a college debater to reverse the logic, a debate technique that begs the questions to the other side. So I'm going to pose 6 points and end with several questions. In more than half the country, APPs have full practice authority, diagnose, prescribe, order lab work and x-rays without physician oversight in more than half the country. 13 states and DC support APPs working independently upon licensure, and another 15 grant full practice authority after transitionary rules. Maintaining a collaborative practice agreement, as you've heard, with a physician can cost thousands of dollars every month, and even in some cases up to $50,000 to even establish the agreement. Thanks to anti-competitive scope of practice laws in 22 states, including Kansas, APPs are barred from working in a hospital even as a volunteer, unless they are supervised by a physician. Some of these restrictive states also impose a variety of bureaucratic hurdles, like the number of practitioners a physician can supervise or the geographic radius of the relationship.
Ginger, 30 seconds.
Yes. So here are the questions I want you to ask yourself. What other U.S. healthcare professional requires a transition to practice? The answer is none. Do cardiologists consult with a cardiovascular surgeon for possible needs of higher levels of care? The answer is no. Why does AARP, the American Hospital Association, the Federal Trade Commission, the National Governors Association, the Department of Veteran Affairs, and IOM all support full scope practice?
Ginger,
and finally,
time.
Thank you.
Next, I have Jamie Harrington, Kansas affiliate of the American College of Nurse Midwives. Welcome to committee, Jamie.
Hello, thank you for allowing me to testify. My name is Jamie Harrington. I'm the president of the Kansas chapter of the American College of Nurse Midwives, and I'm also a certified nurse midwife and a family nurse practitioner. Over 70% of Kansas counties do not have access to maternity care. This increases maternal mortality and morbidity and forces some women in Kansas to drive hours just to access prenatal care. Educated APRNs are sitting on the sidelines available to provide this safe and quality health care to these women. But currently these restrictions are really preventing us from practicing because they're unable to find a physician to sign the collaborative practice agreement. Just in my practice alone, my colleague and I have lowered the rate of C-section from over 30% to less than 11%. Physicians are going to get up here and tell you that if you pass this, that it's going to expand our scope of practice and that we'll be unsupervised. This bill does not expand our scope of practice. It simply removes the requirement for a permission slip to practice. The current law also does not require supervision. A collaborative practice agreement is totally different and is literally just a piece of paper, as you've kind of heard before. It's a permission slip to practice and prescribe. You can get this from a physician in your same practice, in a different specialty, or even a physician 500 miles away. I have my own clinic and have my own patients. I have to pay a physician to sign my agreement. It's not uncommon, like you've heard, for APRNs to pay exorbitant amounts just for this permission slip to practice, or give a percentage of profits to the physicians, even though the physician has no oversight and does not participate in the actual business. This is not okay. This agreement also does not dictate who I consult with, refer, or collaborate for care, or who does my C-sections. APRNs, just like me, already function independently, yet we maintain a communication with a network of providers, including physicians, other APRNs, and healthcare members that we're consulting and collaborating on a daily basis. We don't need a permission slip to do this. The other problem is that physicians are not willing to sign this agreement. One, they don't want to sign it because it implies liability for another person that has their own license and really should be held accountable for their own actions. They also don't want to sign it because we're a competing profession. Why would they sign this for an APRN that's going to open a business possibly in the same town where consumers could have a choice for who they see for healthcare and potentially take some of that business away from the physician? As you know, like they talked about, the FTC has already deemed this a requirement, a restriction of trade, limiting APRN practice and APRN-owned business. I have been an APRN for 10 years, and in that short time, I've had to change practices 5 times because either the physician left, they changed practices, or just decided they didn't want to work with APRNs. This left me unable to practice. Once I was working at a community health center that I had over 400 pregnant women. And because our physician left the practice and they weren't able to find someone to sign the agreement, we basically had to transfer all 400 of those pregnant women out into the community. Some of these women were uninsured and could not even get prenatal care. Some were at the end of their pregnancies, 39, 40 weeks. Thank you.
30 seconds.
Thank you. And
All right,
being
thank
forced to see someone else they didn't know or that they didn't trust, when I still could have continued to see these women. I was already seeing them, but with the requirement for the collaborative practice agreement, it made it impossible. This is unacceptable. Please remove this unnecessary requirement. 24 states, the VA have already removed it. Thank you.
Thank you, Jamie. Next, I have Judy Davis Cole, an RN, AARP advocacy volunteer. Are you with us, Judy?
I'm Chair, member. Yes, can you hear me?
Yes, we can.
Oh, good. Thank you. Madam Chair and members of the I'm also a retired master's prepared nurse and a concerned elder Kansan. Thank you for the time this afternoon to testify in favor of House Bill 2256. Why is our group so concerned about this bill? Our numbers continue to grow. By 2026, to be 95 million of us. Our group is a major consumer and sender of the healthcare dollar. Vitally important to us to have easy access to high-quality, cost-efficient healthcare, especially in the area of primary care. Many issues in healthcare, but one major issue is that there's a shortage of physicians for primary care, and this shortage is projected to get worse over time. There is a solution. In 2018, there were 367,000 advanced practice nurses in the United States. In 2019, 270,000 nurse practitioners, 87% of which are in primary care, and many will practice in underserved rural and urban areas. You've already heard that the advanced practice nurses in Kansas are not allowed to practice to their full extent of their license Some will argue that physician oversight protects the public from poor and/or dangerous care. No. The National Academy of Medicine found no studies that indicate that this is true. Some argue that if collaborative agreements are not continued, then the advanced practice nurses need to be regulated by the Board of Healing Arts, primarily a physician-oriented board. No, nursing is a profession in and of itself separate from medicine, and it always has been. If a physician's order is not perceived by the nurse to be a benefit to the patient, the nurse is legally and professionally responsible to not carry out that order. Physician oversight is unnecessary and frankly, it's outdated. You've already heard the concerns of the Federal Trade Commission on these issues. How are advanced practice nurses perceived in the state of Kansas? In 2018, there was a survey done by AARP of voters age 45 and above in the state. This indicated that 87% of these voters, thank you, voters support allowing advanced practice nurses to serve as the primary care provider of record. So in summary, advanced practice nurses deliver care comparable to, and in some cases better than physician care, deliver safe care with higher patient satisfaction surveys, document quality patient outcomes, they're cost effective, more likely to practice in underserved areas. Please join the other 23 states, the VA system, the Department of Defense, and others who remove these barriers from the advanced practice nurses. We ask you to support and pass House Bill 2256. Barriers to be removed. Thank you.
Thank you, Judy. Next, I have Elizabeth Patton, State Director for Americans for Prosperity. Welcome to committee. Nope, you got to turn it on.
There we go. All right. Thank you, everybody. My name is Elizabeth Patton. I'm the State Director for Americans for Prosperity Kansas. Thank you, Madam Chair, for allowing us to testify today. I think at the end of the day, many of us are engaged under the dome today for a common reason. We want to see our state be better. We want to see solutions happen, and we want to leave our children and grandchildren a place where they are able to live, grow, and thrive in both rural and urban areas. If the COVID-19 crisis has shown us anything, it's that doubling down on today's bureaucratic approach to healthcare won't work. In fact, we are starting to get a glimpse of what's possible by taking a different approach to things like healthcare, one that trusts Kansans rather than holding them back. As policymakers removed barriers to care, it empowered frontline medical professionals to give their patients the healthcare they deserve, and building a patient-centered healthcare system that lowers costs, increases choices, and improves access for millions of people seeking relief. The reforms we are supporting today helps our state do just that. Kansas faces some of the worst provider shortages of any state in the nation. According to the U.S. Department from Health and Human Services, roughly 800,000 Kansans, over a quarter of the state's population, live in areas that face a severe shortage of physicians. That matters for many of the reasons that have already been stated by fellow conferees, because one of those is that it makes it harder for those highly educated nurse practitioners to find physicians to sign these collaborative practice agreements. It means APRNs in our communities are ready to practice nursing and help patients be able to be treated within their scope of practice, and yet are often unable to do so. More bureaucracy and failed government programs do not solve the issue, but removing unnecessary regulatory barriers can make a much greater impact for access to care. This bill is a great example of an easy way to make a real practical difference in our state, and we can remove a piece of paper that changes nothing in what an APRN has already been highly trained to do, to provide a full range of high-quality nursing care within their scope of practice, and deliver this to parts of our states, including those 800,000 Kansans who are experiencing a provider shortage. So I will end with this, which I've referenced also in my written testimony, a study that was done in June by the University of Illinois that compared the effect of Midwestern states who have waived scope of practice laws, as we did, including Kansas, and versus Midwest states that did not. And the study found that states that expanded their scope of practice for nurse practitioners, well, I said that wrong, expanded to full practice authority for nurse practitioners, reduced COVID-related deaths by 10 per day in those states that implemented the changes. So we are asking for those reasons and many of the others stated today. I'll endeavor not to be redundant, but I will ask you to please vote in favor of this bill. Appreciate it and I would be happy to stand for questions at the appropriate time.
Thank you, Elizabeth. Next, I have Eric Stafford, Vice President of Government Affairs, Kansas Chamber. Welcome to committee, Eric.
Thank you, Madam Chair and committee members. Eric Stafford, Vice President of Government Affairs with the Kansas Chamber, here to testify in support of 2256. Appreciate Ms. Columbo moving over to the side rather than behind of the room while I testify, just out of lack of trust over this issue. Healthcare, I was trying to think of an opening statement. All I could think of was healthcare sucks, but it doesn't have to. Ultimately, Kansas has pretty restrictive laws in many areas, and that's really the underlying tone that I'd like to give in our testimony today. Yesterday, we testified on a legal reform bill, and we were told by attorneys that only the Supreme Court's the best place to regulate attorneys, that they're really the best oversight. Nobody else should have any oversight over attorneys in terms of their ethical standards. Today, we're facing something in the healthcare realm that's very similar, that a piece of paper is keeping patients safe when visiting with an APRN rather than a primary care physician or doctor. I think that the quote that's in our testimony from the FTC letter to Majority Leader Hawkins couldn't have said it any better. Well-intentioned laws and regulations may include unnecessary or overbroad restrictions that limit competition. This legislature repealed competition restrictions in the world of wine and beverage sales a few years ago with the Uncork Kansas initiative. So again, I think Kansas has shown that we like to protect people with the use of statutes, and we would would ask that this committee support this bill to allow individuals that are trained in their practice to practice up to the full scope independently, and allow Kansans to benefit from this. As you've heard before, half or close to half or more than half of the states have this independent practice authority. Seems to be working there. People aren't suffering. So with that, be happy to stand for questions at the appropriate time. Thank you.
Thank you, Eric. Is there anyone else that I have not called on as a proponent that expected to be called on today? All right, seeing none. Committee, you do have, let's see, 2, 4, 6, 8, 10, 12, 13 pieces of written only testimony in your information. So now we will open it up for the opponents. And first I have Rachael Columbo, Executive Director of the Kansas Medical Society. Welcome to committee.
Good afternoon, Madam Chair, members of the committee. I am Rachael Columbo, the Executive Director of the Kansas Medical Society. Our association represents all physicians in Kansas in every community of every specialty. And I appreciate the opportunity to stand before you today in opposition to House Bill 2256. 3 minutes is a very difficult time frame to respond to all the things that you have heard today, but I promise you I am more than happy to meet with you after this, and I hope that the testimony, the attachments I've provided, and what you'll hear from other folks will answer many of those questions, because there is much to be discussed. The most important thing that I can tell you about this bill is that the Kansas Medical Society does not oppose the independent practice of nursing. House Bill 2256 has been brought to you under that guise that this is just about nursing, this does not expand the scope of practice, and that there are restrictive requirements for nurses to practice in Kansas today. We are not opposed to the independent practice of nursing, but that is not what House Bill 2256 establishes. This bill provides for the independent practice of medicine by non-physicians, specifically APRNs. We can talk a lot about that. The words that have been used today, independent practice, full practice authority, collaborative practice agreements, each of them deserve an understanding. We do not have time to unpack all of them today. It has also been stated that 23 states have full practice authority and that this same bill has passed in 23 states. That is false. There are a variety of laws that are governing the practice of medicine and the practice of nursing across the United States. They are not all comparable. There are only 3 states that have unrestricted and unsupervised authority for APRNs in the United States today. So we should talk a lot about that, but we won't have time to today. The reason that the KMS opposes the independent practice of medicine by non-physicians is that we believe training and education matter. Before you, you have a couple of things I would point to. One is testimony from the AMA President, James Madeira, on a similar bill in Mississippi, House Bill 1303, that talks about the differences in training and education between APRNs and physicians. The second is a wheel that describes the differences in hours. These are important for you to understand because I hope that what you heard in the testimony today is that they believe they can provide the same level of care, serve as a primary care provider in exchange for a physician. Very simply, this bill, House Bill 2256, allows an APRN to serve as a physician, period. There is no distinction in what they have provided and the Healing Arts Act, which is KSA 65-2869. In the Healing Arts Act, it specifically delineates that diagnosis, prescription, independent treatment and management of ailments, as well as authorization of other healthcare supervision is the sole purview of a medical doctor or a doctor of osteopathy. Every other healthcare provider, every other one in the entire state has a statutory scope of practice or is regulated under the Board of Healing Arts because they participated in delegated medical acts. So what you've heard the nurses say is, well, this is not an expansion of scope because we currently perform some of these duties. These duties are delegated medical acts, and they are supervised through the physician's licensure currently. If you take away that physician's supervision, what you have is the independent practice of medicine. So the question before you today is, are these professions different? Is their training and education different? Does that training and education matter? What does this mean for your parent and for your children? It's been posited that this will provide more access in rural areas, but in other states that have passed similar provisions, either with reduced supervisory requirements or with expanded scope, they have not seen more APRNs located in rural areas. I also provided for you a map where this was recently enacted in Wyoming. Please look to that and see that they passed it under this exact same guise. It did not result in that. So we don't have to wonder what will happen. We do have evidence that shows this, and I would tell you that many of you are new to this issue. You're new to this committee. It's a lot of information, and I know it's high intensity, but this is not a new issue. It has been brought before this exact body for 30 years in a row. We have continued to meet with the APRNs and talk about ways to improve collaborative practice agreements.
Rochelle, time.
Thank you very much.
All right, next
Please oppose House Bill 2256.
Next, I have Dr. Jennifer McKinney, President-elect of the Kansas Academy of Family Physicians. Welcome. Good to see you again.
Good to see you, too. Thank you so much, Representative Landwehr. I'm a family physician in my hometown of Fredonia, Kansas, in southeast Kansas, where I've been for the last 11 years. I'm speaking today on behalf of the Kansas Academy of Family Physicians, as well as the Kansas Medical Society, as we are aligned in our thoughts on this matter. So as we learn and grow in medical care in our state and in our country, we find one theme that keeps coming up, that team-based care prevents disease, keeps people well, and saves lives. At no other time in history has this been more. Trained for 11 years after high school to be able to do what I do. I had 20,000 clinical hours of training before I stepped foot in my practice. And to be fair, there's nothing special about doctors, right? We're not better, we're not smarter. We just did all the training. We did the things that we needed to do to practice medicine. And luckily, that's available to anyone. Anyone can practice medicine if they go through the training. We do not oppose, as Rochelle said, the nurses, we don't oppose nurses practicing to the highest level of their training in nursing. However, the training is not the same. I was particularly surprised by the wording on page 6 of House Bill 2256, where the proposed scope language acknowledges it to be additional to the practice of nursing. I employ an APRN, and we work great together. I depend on her to help me take care of patients, and I help her take care of patients as well. And we depend on numerous people on our healthcare team. I was not trained to do all the things that all the other people on the team were trained to do. It's with this team approach that our patients are ensured that they're receiving the highest quality of care. I'm a rural doc, and rural medical care is complex. Sometimes I'm the only doctor within a 15-mile radius, and it gets scary really quickly. Like if someone walks in with a stroke, if there's a multiple car pileup on the highway, or if one of my patients is suicidal in my clinic, it would be nice to say, yeah, we'll pick and choose what we take care of in the clinic. Well, that's not reality. We take care of patients when they need us, and we take care of whatever walks in the door. The complexity of rural care is why, included in my 20,000 hours, I had at least 1,000 hours each of clinical training in psychiatry, neurology, trauma, and critical care. And that's just part of our training. And that alone with that specialty care is more than what we see with the clinical training with APRNs. It's troubling to me that this bill is being partly sold as a way to recruit providers to rural areas in our state. It's true that our rural communities in Kansas need way more healthcare workers from every discipline: physicians, nurses, radiology techs, CEOs, paramedics, everybody. But there are no barriers at this time for those people to come to rural communities. It's just not happening. We have a shortage of nurses in Kansas. We don't have a shortage of APRNs. We have one of the top 3 per capita states with APRNs. And the problem is there's no reason to believe that this bill will entice more APRNs to come to Kansas or practice in rural communities.
30 seconds.
Thanks. There's a distinct difference between the practice of medicine and practice of nursing, and sometimes that can be confusing. But it's also not understandable how 2 professions with distinctly different training hours, 1,500 versus 15,000, could have the same scope of practice. So we hope that you'll keep the patient care at the forefront of your decision making. But if you do advance this bill, we recommend at a minimum that APRNs be regulated by the Board of Healing Arts. So please help us continue to work toward the model of care that we know works best for our patients, team-based collaborative care, and please oppose House Bill 2256 and focus on stronger communities and stronger health. Thank you.
Thank you, Jennifer. Now we have Vicki Whitaker, Executive Director of the Kansas Association of Osteopathic Medicine.
Yes, I'm on. If you can hear me. Okay, I am Vicki Whitaker, the Executive Director of the Kansas Association of Osteopathic Medicine, and I'm here to offer opponent testimony, and pretty much it's mostly been covered, but I guess I think I'll address one of the points made that, you know, APRNs have a transition of care and no one else does. Physicians go to medical school for 4 years, and then they have a residency before they are allowed to practice. That would be a big transition of care of about usually 3 years, I think is going to be the minimum. They have 10,000 to 12,000 hours just to be a primary care physician, and primary care physicians have they treat everyone. They have to refer, they have to be very familiar, they have to know who they're treating. And another point I want to make is nurse practitioners are a very, very valuable part of the healthcare team. Historically, nurse practitioners were to enable physicians to treat more patients by giving patients the opportunity to spend more time with someone who could concentrate on what their medical, their diet, their exercise, their medication regime, how they, minor a common cold, things like that. And I'm not saying that nurse practitioners can't treat even more complex conditions than that, but that is the purpose of them when they came into being, was to help physicians by allowing other people with a background in healthcare to meet with these patients so the physician didn't have to do that. I would also say that I also believe this is the practice of medicine without a license. Physicians don't just go to school for all the years they go to school and have all the years they spend in residency, all the money they expend just to do it. Medicine is an art and a science, and the art comes in from all of their treatment of patients, all of their training, all of their experience. Every person presents a little bit differently. And I want APRNs as part of a medical team. I just don't want APRNs. I should out with no one to at least look at what they're doing and say, are you sure this is what's going on? And, you know, I've heard in the past that APRNs say that all APRNs want this. I know some APRNs and they don't want it, but you don't hear that. You hear they all want independent practice. I don't believe that's true at all. And I just don't think that I want my health care, if I have a serious medical condition, I don't want just, and I won't say just, but I don't want the only healthcare I can access to be an APRN. And I'm going to leave it at that. And I probably misstated a few things, but I do appreciate the time. And my physicians do oppose this bill.
All right, thank you very much for being with us here today. Somebody's got their audio turned on. Okay, is there anyone else that was an opponent that expected to testify and I did not call upon them?
Dr. Christy Clark.
Okay, Christy, you're the president of the Kansas chapter, American Academy of Pediatrics. Go ahead.
Yes, ma'am. My name is Dr. Christy Clark. I'm a board certified pediatrician with over 20 years experience as a physician, and I've lived in rural West Kansas for 10 years. I serve as president of the Kansas chapter of the American Academy of Pediatrics, and I'm here on behalf of the pediatricians in the state. We represent most pediatricians, about 400 pediatricians, and they're in opposition to this bill, even though they see nurse practitioners as an incredibly valuable member of a physician-led team to take care of patients. The reason why we're in opposition of this bill is because we do not have any evidence that it will increase access to healthcare, particularly in our shortage areas such as rural medicine. Other states that have been studied that have allowed for independent practice of nurse practitioners have not seen increase of access in healthcare. I'll be able to speak to this a bit more. Also, there's been studies that show that this can increase cost of healthcare itself and increase the cost of liability insurance for the nurse practitioner, which could be very prohibitive to practicing independently. For example, my husband is a family medicine physician, and he does full spectrum family medicine, and his malpractice rate is 20 times that of our nurse practitioner's rate. I feel like my area of expertise that I need to speak to you today is not as a pediatrician, but as a rural physician. I work in a town of under 1,000 people in a county with less than 2,000 people. And I feel like I need to advocate for all the rural providers, including the rural nurse practitioners who do not want this. They do not want the collaboration to be eroded. My family medicine husband, who I have worked with for 14 years, says that our nurse practitioner partner is absolutely the best physician he's ever worked with. I try to not take that to heart. We're still married. I collaborate with nurse practitioners. I precept nurse practitioner students. My own primary care provider for myself and my children is a nurse practitioner. However, he does not want to be doing this without collaboration. Currently in Kansas, nurse practitioners have a lot of latitude. They can work in the clinic. They can admit patients to the hospital. They can round in the ER. That's not true in every state. I moved here from Texas where they could not admit to the hospital. My sister's a nurse practitioner in North Carolina. She's not able to prescribe medications. Currently in Kansas, nurse practitioners enjoy a lot of freedoms and latitude. They're very valuable. And what I want to point out to you, though, is that in rural Kansas, there is not an avenue for independent practice for nurse practitioners. In rural Kansas, the model is a critical access hospital with an attached rural health center and also a long-term care. And this falls under the auspices of CMS. And as such, a nurse practitioner can admit, but has to do so under the supervision of a physician. A nurse practitioner is not allowed to write for oxygen, for medical necessity, for a Medicare patient. There are simply things that only a physician can do, even if you change this bill in the state of Kansas. We must continue to work together as a team to take care of patients. I have looked with nurse practitioners in areas of healthcare shortages at starting a clinic outside of the RHC system, and it is cost prohibitive to do so. I do not see this increasing nurse practitioners in rural America at all. It will not help our shortages at all. And I don't see anybody being able to afford to open a clinic. If I can't do it with a nurse practitioner, none of the rest of you can, not in rural America. The question I have is who then is going to benefit from this financially? You must ask that question. It is people outside the state of Kansas, such as the big box stores, the Walgreens, the big hospital organizations that own hospitals within Kansas, and also the insurance companies who want to hire nurse practitioners and cut out the physician because they can do it for less. Looking at this 4,000 hours, I showed it to my sister who's a nurse practitioner. She works in geriatrics, and she says, okay, so I have 4,000 hours in geriatrics. Can I see, thank you, can I see pediatric patients? And the answer to that is that's a big question. I, as a pediatrician, do not work independently. I work under my board, American Board of
Christy, time's up.
Oh, thank you, Madam Chairwoman. Thank you very much.
All right, thank you for joining us. Was there anyone else that was an opponent that I did not call upon? All right, committee, okay. Doug, were you wanting to testify? Yes, please. Okay. Then we have a neutral, which is Doug Smith, Executive Director of the Kansas Academy of Physician Assistants. I should have known that Dave wrote it down here right, and I just had to second guess.
That's all right. Good afternoon. I am Doug Smith. I am with the Kansas Academy of Physician Assistants. Appreciate the opportunity to appear here today. And we do appreciate the opportunity you provided us last year to participate in the roundtable you had on this same issue. We're here today to remind the committee members who were here last year and to share with new committee members that the PAs in Kansas have concern about this bill if it should pass and the impacts that it may have on their profession. We have 1,300 PAs in Kansas who are trained medically, can diagnose, treat, and prescribe, and they work as a part of a physician-directed healthcare team. Collaboration with physicians is the foundation of their training, and we're not here to seek to change that, but we are concerned that there will be lost job opportunities because of some of the administrative requirements that are in place to supervise PAs, that there may be fewer jobs for PAs, there may be changes in access to healthcare. Our profession is projected to grow and expand, but we are concerned about the threats. Traditionally, PAs had been employed by physicians and worked in solo practices and in small groups, extending the physician care. However, today, a majority of both physicians and PAs are employed by large health systems who are looking for efficiencies and cost controls. Some of that affects PAs because of the administrative requirements that might be there. So we ask that as you proceed with this bill, you keep in mind other providers that may be impacted and that we may need some discretion, some changes and modifications to the PA Practice Act to allow us to remain competitive in the healthcare field and provide care to our patients as well. We'd be happy to stand for questions at the appropriate time. Appreciate your consideration.
Thank you, Doug. Appreciate it. Is there anyone else that had expected to testify as neutral that I did not call upon? All right, seeing none. We have written testimony only from Tucker Poling, the Executive Director of the Kansas State Board of Healing Arts. At this time, committee, we will open the floor up for questions. Representative Epley.
Thank you, Madam Chair. And so I'll ask, because we don't have much time, that we'll be brief in our answers, but we'll do the best we can. I would like to call back Elizabeth Patton to the mic, please. So, Elizabeth, I really appreciated your testimony, and I appreciate the need for access to care. And you made sort of a broad statement that 800,000 Kansans don't have adequate access to care. Do you know by specific counties where that exists? Again,
So-
please be brief.
Sure. That is a number off of the U.S. Health and Human Services website. I would be happy to provide you with additional details. I believe I also cited it in my written testimony, but I would be happy to circle back with you on that. But it does have a breakdown of what qualifies that by their definition.
Okay, at some point, I'd like to see it county by county because I have different information, but I'd be happy to visit with you later. Thank you very much.
Yep.
Number 2 is Eric Stafford. And Eric, I'm going to ask you maybe kind of a difficult question, maybe out of your wheelhouse, but I'm going to put you on the spot a little bit. And I'd like to know, if we lift collaborative practice agreements through this bill, and let's say they're gone, and we're now talking about full practice authority, which is in the terminology of this bill, versus the practice of medicine, which is, for me, synonymous. I want you to try to explain to me how you see those differences, full practice authority versus the practice of medicine.
I'd say, Representative and Madam Chair, that's probably directed best towards the healthcare professionals who have introduced the bill. It's our understanding that they're not trying to expand their scope of their training at all. So I'd probably defer to them. Let them explain the difference.
All right. Well, then let's ask Amy Seipel, the president of the Kansas APRNs, and just for a brief answer to that, if possible, please, Amy. If you're still on with us.
This is Nicole Abatis. I believe Amy had to drop off, but I'm happy to answer.
That'd be fine, Nicole. Thank you. Thank you, Chairman.
Yeah, thank you so much, Representative, for your question. So the difference between practicing medicine and full practice authority, I believe, was your question. Full practice authority is the APRN being able to practice under their current education and national certification. That is very specific as to what services they can provide and for what population they can provide it for. So I think the practice of medicine, although all-encompassing, APRNs do not practice general medicine. They practice in a very specific area of advanced practice nursing that's defined by education that places them, if you will, into a lane. And in order to change lanes in advanced practice nursing, they need to go back to graduate school. So I think that's the key difference. We're talking about practice under their education and training, not anything outside of that.
But excuse me, and so I'll just beg to, nicely as I can, to ask for more clarity, because once you lift the collaborative practice agreement, from my perspective, it seems like we're doing parallel work, whether it be the practice of medicine or you want to call it a different nursing function called full practice authority. But I don't see the differences when it comes to basic medical functions.
Yeah, so if I can respond to that. So this bill also includes the requirement that APRNs hold and maintain national certification. What that national certification is a definition of what their scope is, and that scope is limited. And so you're not able to practice as an APRN outside of your national certification. So that does limit the types of services that an APRN can provide. For example, if a pediatric nurse practitioner was wanting to suddenly saw a mental health care need in their community and got interested in the topic, they wouldn't be able to, without going back to graduate school, passing a national certification exam, and then becoming nationally certified and licensed in the state of Kansas, be able to actually practice in mental health. So it's very narrow and specific to them. It may not apply across into other professions, that same type of specific training, but it is unique to advanced practice nursing and does not give them any sort of unlimited scope.
All right. Well, we could talk at length and bore everybody to death with that. Thank you very much. Finally, Nicole, I'll ask you, the Board of Healing Arts, you gave the testimony that you thought it was physician dominated. Do you know how many physician members, MD members, are on the Board of Healing Arts?
Well, I was referring to, I believe that there's also MDs, ODs, as well as chiropractic doctors and others. I believe that they make up the vast majority of the Board of Healing Arts in Kansas, is my understanding, and I know the FTC commented to that too.
Are you aware there are chiropractors and podiatrists on the board?
I am aware of that, thank you, yes.
Okay, so the majority of the members are not MDs on the Board of Healing Arts. Are you aware of that?
Correct, MDs, correct. They make up, I think, 5 members of the board, if I have that right.
I think they make up 4 or 5 members, yes. All right, and finally then, the last question for you is on the Board of Nursing, and this really comes from our written testimony, and it's just a question about trying to understand how a board that's never really been authorized to practice medicine or in my opinion, the same thing, full practice authority, the Board of Nursing, how they're going to be able to really make determinations on the scope of practice that includes the practice of medicine. How's the Board of Nursing equipped to do that when they've never done it before in this realm?
So thank you for your question. So the Kansas Board of Nursing has been regulating the current scope of practice for APRNs, both their prescribing and their practice. Again, they've been regulating them since the 1970s, and there are 47 other states that do the same solely under the Board of Nursing. So because the scope of practice isn't changing under this bill, meaning an individual APRN who performs services right now in Kansas today to treat their patients, they're going to be performing those same services after House Bill 2256 is enacted into law. So the same appropriate expertise that they have today in Kansas under the Kansas Board of Nursing is that same expertise that's going to be needed to regulate these individuals, again, after this bill is enacted.
Thank you very much for your answer. I think we could bog down in semantics all day, but thank you very much. Thank you, Madam Chair.
Representative Parker.
Thank you, Madam Chair. I have a couple questions. I'll try and be as quick as possible. Nicole, if you don't mind, since you volunteered the first time, you may be stuck there, but feel free to defer. I wondered if you could speak to, on page 6 of the bill, lines, oh, sorry, I lost my spot here, 15 through 27. To me, as someone who doesn't work in healthcare, this sounds to me like expanding the scope of practice. Can you walk me through why is this section necessary if we're merely trying to do away with a collaborative agreement?
Yeah, can you refer to those line numbers again, Representative?
Yes, I'm sorry. It was page 6, lines 15 through 27 is the new language there.
Yeah, so that, right, correct. So that definition is not an expansion of scope of practice. Those are all things that APRNs in Kansas can do today. I mean, conducting an advanced assessment, ordering, diagnosing, those are all practices and services that APRNs provide today. This definition of professional nursing as an advanced practice registered nurse is from the national model. So that is just defining what APRN practice is as opposed to what registered nursing practice is or licensed practical nursing. This does not, again, increase what those APRNs can do because those bounds are set not only by licensure, but in this bill by that national certification. The APRN cannot practice outside of that space.
Thank you. That's helpful. The other question I had for you or any of the proponents is, one of the opponents referenced that there are different models across the 23 states that have some version of independent practicing. Why is this the one that we chose? Are there others that are acceptable? Are we open to any of the models across 23 states, or is there a specific reason that this language is superior?
Yeah, thank you, Representative, for your question. And so, without knowing exactly what was being referred to as different models across all of the states, I would, as someone who works across the different states, the national model for APRN regulation is the national consensus model, which was developed in 2008 to create some uniformity between the states in regulating APRNs. And so that is the model, and that's some of that language, like you just referred to on page 6, comes directly from that model. What is different among some states that have implemented full practice authority? For starters, some have never had restrictive collaborative agreements. So we have states that since the 80s have had regulation of APRNs and they've never had these agreements. So there's no language in their law that's really exiting from these agreements, like the 4,000 hours that we have in our bill is doing that. It is meant to facilitate a transition from the current practice into full practice authority for APRNs. That number, 4,000, it does differ, and that may be what they were referring to, is what is the appropriate or what is the right number to hit. We know that 4,000 hours is nearly 4 times that of neighboring Colorado, twice that of Nebraska for their nurse practitioners, and in South Dakota as well, they only have 1,040 hours, whereas we have, agreed to a number that's much higher than that for this bill. So again, without knowing what they were saying about these different models, I can just speak to that there is one national model and states facilitate that and incorporate it into their statutes as appropriate.
Thank you. Madam Chair, I do have a question or two for the opponents, but I'm happy to jump on the back of the line if you'd like.
Go ahead, because then we'll have Representative Lynn, Blex, and Reese after you, so go ahead.
Thank you. Rochelle, I'm going to start with you, but again, if you want to defer to anyone else, that is fine. And I apologize, this might be a little bit broad, but as the proponents for this bill outline some of the points that they're trying to solve, for example, in some cases, there are collaborative agreements that there's really no actual oversight from physicians, access to health care, allowing them to practice to the full extent of their qualifications. I heard a lot from opponents about not being fully opposed to those aims, but having maybe issues with this bill specifically. Is there an alternative bill that's been proposed to deal with any of those things? Is there other legislation out there that has already been proposed or that you would be open to address some of those issues?
Yes, thank you, Representative Parker. I appreciate that question. There have been a variety of proposals over these many years, as I've explained. The most recent would have been in 2015. I believe it was House, I'll find the number, but now I just lost it because I gave the year. I'll find the bill number for you. I thought it was 2215 or 2218. I'll look for it. Which would have allowed for some of these things, both a more narrow definition of scope of practice that more appropriately acknowledged the differences in training and education, as well as some oversight for those delegated medical acts through the Board of Healing Arts. There are other models also. You heard from the physician assistants today. So they work under the direct supervision of physicians. They have collaborative practice agreements. They didn't get a chance to talk about this very much. It's really interesting. The professions out in the real world, APRNs, PAs, and physicians all work really, really well together, but they do have different models for how that happens. The PAs have a very prescriptive model that a very, very specific type of collaborative practice agreement. They have limitations on how many physicians can regulate or how many PAs can be supervised by a single physician. They have distance limitations. They have definitions of direct supervision and indirect supervision. The interesting thing about this, as we've worked with the nurses over the years to try to accomplish some of these goals, to recognize the differences in training and education, the different roles on the team, is that actually what we have today was the result of one such compromise, which was to say, let's have a really broad collaborative practice agreement requirement that just says a physician has to be in some way involved in supervising the acts that you perform. It's not really defined in statute what has to be involved in that collaborative practice agreement, where it is for some other healthcare provider types like physician assistants. And there's not a limitation on distance. Right now, a nurse can practice anywhere in the state so long as they have a collaborative practice agreement. And so, they argue, well, these aren't meaningful. We would love to see those, we can make those more meaningful. We would argue in the absence of that, they need to have a distinction in their scope of practice between nursing and medicine. So I would answer yes. There are a number of models which could maybe accomplish what we're talking about today, but to reduce this as the independent practice of nursing is not appropriate, and it doesn't exist in 23 other states, as been stated. There are a variety of models, but Kansas is listed among these other states. I'm sure you know that we work with our counterparts across the nation as someone that has quasi-independence. So in other states, there's somebody out there testifying saying, we wish we had what Kansas has, because they have really broad authority, as it was mentioned by Dr. Clark. APRNs are able to prescribe, for instance, here. And those things are really different state to state. They have admitting privileges, et cetera, et cetera. So it's not apples to apples, but this model would be the least, it would absolutely eliminate any distinction between the practice of medicine and the practice of nursing, and we believe that's a bridge too far.
Thank you. Thank you, Madam Chair.
Representative Lynn?
Thank you, Madam Chair. Rochelle, you probably could answer this for me. In the couple years I've been up here hearing about this bill, the common denominator seems to be the collaborative agreement. And in looking for a compromise, I'm not sure that we've focused enough on that. So first of all, I'm wondering if you can tell me which board is responsible for holding on to those collaborative agreements?
So that's a great question. In this instance, I think the Board of Nursing has to. And so, but they are, again, when you look at other healthcare professions that require collaborative practice agreements, for instance, the PAs, those come to the Board of Healing Arts because both professions are regulated there. And then they have a council which goes through updating those regulations as often as necessary and have representation on the board. So, or work together on the board to bring those because it is not, and I think that's an important point, a majority of physicians on that board. So those FTC arguments actually don't apply in Kansas. So really different when you look at those different professions.
Okay, and if I may, Madam Chair, I'm wondering if we can maybe modify some of those collaborative agreements and how they're structured so that there's a little bit more consistency. I know one of the concerns is, if a doctor dies, then they no longer have a collaborative agreement. Is there any sort of room for compromise in establishing something like a grace period, for needing to get a new one or to renew one, so that if something like that were to happen, they have time? Or is there a way for either maybe the Board of Healing Arts to either host or maintain some sort of last minute or last resort sort of option that could be temporary until a collaborative agreement with an actual physician could be reached? It seems like maybe this is the spot for compromise here, that maybe we can reach an agreement.
Representative Lynn, I appreciate that question and would say that we have been very open to that for a long time. Again, if you look at the way that physician assistants are regulated, they address every single one of those things. And we would welcome that. That's not something that the APRN community has liked to do. And while we understand that they are dissatisfied with the current collaborative practice agreement, they have been unwilling to embrace a different model. I would also tell you that nothing in law right now restricts them from having a backup physician listed, from working to establish who that backup would be, how that would work if the physician dies. That's what actually happens in the physician assistant collaborative practice agreements. They both have a designated, whether you're on vacation or you die, they've got somebody who is designated. Theirs are very prescriptive. The APRNs, when we put this the last compromise together about 15 years ago, did not want to do that. They said, we don't need that. What we need is something that takes each individual nurse and each individual doctor into account, and so that you can do the full breadth of your training, depending on what that is, because a nurse right out of nursing school is not the same as a nurse who's been in practice for 30 years, and we want our collaborative practice agreements to reflect that. And so that's how we got the collaborative practice agreements we have today, is based on what they told us they needed. So I would tell you we're very open to that. We would love to see them structured as they are by the physician assistants, which are extremely, they work well. They are frustrated because, as you've heard, they're not the same in the way they are regulated, although that affects employment. But we would welcome them to be much more prescriptive so that there is clarity and that does provide the meaningful oversight they would like.
Madam Chair, would the APRN side or the proponent side be able to answer that?
Go ahead. Who wants to answer it from the APRNs?
I can answer it. I'm Jamie Harrington. I'm the president of the Kansas American College of Nurse Midwives. So what Rachael is saying, currently, the problem is we are not able to find physicians that are willing to sign these agreements. That is the major issue. Physicians, I don't blame them. They don't want to sign them because they don't want to be liable for someone else who has their own license. And don't you think that we should be held accountable if we have our own license? The other issue is that we have compromised. We've been working with KMS over the past 4 or 5 years, and that is the reason this transition to practice is in the current bill, is that is our compromise. It is one of the highest, like Nicole said, in the states. It's 4,000 transition to practice hours.
Thank you, Madam Chair.
Representative Blacks.
Thank you, Madam Chair. This question is, I have a couple questions. One's for Rachael Columbo and one for Dr. McKinney. Rachael, appreciate your testimony. You say that you do not oppose independent APRN practice and that training and education are important. What is your solution to the lady you just heard on the screen, to those practices that's been independent for the 20 years with 400 patients, 5 or 6, 8, 10 employees, all of a sudden lose their collaborating physician through either a death? And I know you advocate going under the Board of Healing Arts, and if so, how would going under the Board of Healing Arts advocate that if they still don't have a, quote, supervising physician in your words?
Well, I want to try to answer this, the couple different parts. To answer what was just said about why would a physician sign a collaborative practice agreement when these individuals, these other providers have their own license. That's true, but their licenses provide for different privileges. And by the term, I mean privilege, the privilege of providing patient care that affects the life or death of a human. So those privileges are granted, again, based on training and education requirements. With all other healthcare providers, those are stipulated by statute and or are delegated through those supervisory requirements. So we would say that, you know, why, you asked, why would we, how would bringing them under the Board of Healing Arts?
How do you correct a clinic that's been thriving for 20 years that all of a sudden loses a physician and you've got employees and APRNs out, as well as patients that need that access? How would your solution, what solution do you have for that? Is that not important to you?
It is important, and I think you bring up two really important points here, which is that currently today in Kansas, there are APRN-run clinics that are providing basically independent care because they have a collaborating practice agreement, which provides both patient safety and malpractice coverage. And you say, well, what would happen if suddenly they can no longer practice independently the way they are today because they do quasi-independently? We would say, to Representative Lynn's point, there are other models for how to ensure that we have backups or other processes in place to make sure those collaborative practice agreements which protect patients exist. So, you know, I don't think it has to be one or the other. I don't think we have to say either physicians and docs are the same thing or patients suffer. We just don't think, we think there are different options.
Okay, thank you. Dr. McKinney, if you could step up, please. Thank you for being here. The snow's deep in southeast Kansas, isn't it? You have, did I understand you to say you employ an APRN?
Yes, I do.
Just one or two, or how many?
I have one APRN.
Okay, how is that relationship working? I'm assuming you have more than one office. You have two, and he or she works somewhat independently. And when we look at this collaborating agreement, to me, when I read that, it looks like in the same building, it's a good process. Once you get a physician 30, 40, 50 miles away, not so good, because it becomes a worthless piece of paper that you're putting your license at stake and for somebody else's action. And basically, how is your situation working? How often does she call you in? And I'm assuming it's she, I apologize for that. Call you in and say at the same time in the patient with both of you in the room, or how does that work?
We actually have a variety of different ways that we do it. I love my nurse practitioner. She is one, I mean, she's become one of my closest friends as well. And we have a great relationship. Either come into the room and see this patient and help figure out this problem, or at the end of the day, we run through patients. And it depends on how crazy the day is. My response to your question about if the difference between that and somebody 50 miles away, I really believe it's all about relationships, and I believe the responsibility falls to both parties. We as physicians, just let that happen either. I mean, we have to take responsibility for that. Let's check in. Let's make sure that we're doing that and talking on a regular basis, whether it's once a day, once a week, whatever it is. But also the nurse practitioner needs to make sure that that happens too. So I do think we each have a responsibility to make that piece of paper, or truly that collaboration, a true collaboration, without just going on about our business because we can. So that would be my response to that. I hope that we see those relationships grow. Okay, thank you. Have you had previous APRNs, or? I had one other APRN. Did you ever have to fire one for for poor outcomes? No, I've only had the two, luckily. So they've both been very good APRNs. Okay, thank you.
Representative Reese.
Thank you, Madam Chair. I think Nicole Lavanos might be able to answer my questions.
Nicole?
Yes, I'm here.
All right, go ahead, Representative.
Nicole, there were two things that I've heard through the testimonies that kind of took me aback. I wasn't aware of this. I've worked with nurse practitioners in mental health before and have run into the issues of not having a psychiatrist to do that collaborative agreement. So I didn't know that the collaborating physicians can place limits on what they can treat. So the physician's limitations means if they have limitations, then therefore those limitations are imposed on the nurse practitioner. Is that correct?
So because these agreements are essentially, they're mandated by statute, but there are no restrictions that say that these agreements have to include practice restrictions, prescribing restrictions, et cetera. And that's really done on that, contractual basis between that practitioner and their collaborating physician. So there are APRNs. I know of many, many stories where APRNs aren't able to care for Medicaid patients because their physician doesn't care for Medicaid patients, or they're not able to prescribe a certain drug because it may interfere with the types of practice that their collaborating physician may be practicing. So yes, it is possible that there are restrictive agreements that would limit services that APRN can provide. Again, that would not be a scope of practice issue, because they would be able to practice with another, collaborating agreement that allows them to practice to their full extent of their scope.
The other thing that I heard was that APRNs have to pay the physician to sign the CPA?
So again, that depends. Yeah, so that depends. In many cases, yes. I'm working on a bill right now in Mississippi where we are, surveying APRNs and finding that APRNs are sometimes paying upwards of $12,000 a month to their collaborating practice physician. And so it does vary what the going rate is, and it may be that it is higher in areas where there are less, less practitioners, or it may be, it just varies from state to state and from agreement to agreement. These are, required by statute, but they are private contracts between these two individuals. So we're unaware, unsure of the exact terms of them.
Madam Chair, one last question.
Okay.
Please, thank you.
Just so you know, Representative Woodard, she just took your question.
Sorry, Brandon. How many CPAs can a physician sign on, or how many contracts can a physician sign off on at any given time?
Yeah,
Are there
so
limitations, maybe?
I would defer to either Jamie or Marilyn if they're on the line to speak to that specifically for Kansas.
Hey, this is Marilyn. To my knowledge, there's no statute or regulatory language that describes the limit of the number of agreements a physician can sign.
Thank you so much.
All right. Okay, Representative Woodard, we'll give you your question back.
Thank you, Madam Chair, and thanks for indulging me since I'm the temp here. I had a question about, I know the governor had an executive order that temporarily did this, and we extended it through House Bill 2016 and more recently through this spring. I'm wondering if we could hear from maybe a proponent and opponent as to how that's worked so far in the pandemic with APRN's independent practice authority.
Okay. We could, if we can get through the other three questions, and then we could come back to that. Is that all right?
Thank you.
Okay, I have Representative Barker, Carlson, and Berquist. Representative Barker.
Thank you, Madam Chair. Rachael Columbo. I've been on this committee a few years. How many nurse midwives do we have in Kansas today?
Less than 20.
Less than 20. I understand there was only one that actually has met all the criteria set up by the Board of
That's a joint committee of the Board of Nursing
Right.
and the Board of Healing Arts.
Because we worked to compromise, and I was a young legislator. I've never been young, but I had not been here very long. And of course, we looked at compromise, and we took the nurse midwives who practice a specific part of medicine, and we agreed. They wanted to stay under the Board of Nursing. We agreed to put them under the Board of Healing Arts. And it hasn't went real well.
I know what you're saying.
And I did not go to lunch. It has not went well. So sometimes compromise is not a good thing. You've taken a profession of nurses and almost ran them all out of the state of Kansas. Would that be an accurate statement?
No, sir. There were eight midwives in practice when that bill was passed, and it is not under the Board of Healing Arts. It is jointly regulated by the Board of Nursing and the Board of Healing Arts. And you passed a scope of practice in that bill,
Right,
which
we
was
did.
then relitigated through the regulatory process.
And it was a compromise language. It's
Yes,
all
sir.
about turf.
It was not our
when
bill.
it comes to
It was brought by
healthcare.
a legislator.
Some people have it, other people want part of it, and nobody wants to give it up. But I remember we had a psychiatric nurse out in western Kansas who had a 80-year-old psychiatrist that she worked for. She had a collaborative agreement. Well, he wanted to retire. She had several hundred patients, and she did not know what was going to happen when he retired because there's no other psychiatrist out there. And I'm trying to do some research to find out what she's doing today and what happened to her patients. That's all I have, Madam Chair.
Thank you, Representative Barker. Representative Carlson?
Thank you, Madam Chair. And I'm not sure who this should be addressed to, whether it's going to be Rochelle or what, but I was looking here at this wheel and about how many hours, how many years, training, experience. I know that dentists aren't on here. There's a lot of other ones. But I'd like to know, so most doctors have to be under the Board of Healing Arts. Are there any doctors or anyone, I mean, if it's a chiropractor, I mean, who does not, that is any type of a physician that has any physical contact with someone, who does not have to be under the Board of Healing Arts?
I thank you for that question. So all physicians are under the Board of Healing Arts. Medical doctors and doctors of osteopathy are defined as physicians. They practice medicine and surgery. But they also regulate at the Board of Healing Arts the doctors of chiropractic, as well as 13 other health professions, PTs, PAs, a podiatrist, a host of other things. But there is an independent board of optometry. There is an independent board of dentistry and the Board of Nursing. Up until this time, those three independent boards of healthcare professionals have in statute a prohibition against that very statute that I referenced, 65-2869, which is the practice of medicine and surgery. So our position is if you're going to eliminate that restriction against the practice of medicine, you need to be under the board which regulates the practice of medicine. Otherwise, all healthcare professions which in any way overlap or provide direct patient care that touches the practice of medicine are regulated by the Board of Healing Arts. Thank you for your question.
Thank you. Thank you, Madam Chair.
All right, Representative Berquist.
Thank you, Madam Chair. I think because I'm most acquainted on the screen with Nicole Lavanos, I might ask this question. The nurse midwife, I believe. The question is, a two-part, but it's all at one time. Have the APRNs agreed to contributing to the Healthcare Stabilization Fund within this plan, and what does that contribute to the cause?
Yeah, thank you for that, Representative. So within this bill, it is required that APRNs participate in the Healthcare Stabilization Fund. I would actually turn to my colleague, Marilyn Douglas, who may be more familiar with some of the details.
That'd be fine.
Representative, hi, this is Marilyn. Thank you for your question. If you remember, we mentioned some while back in testimony that we have made some compromises, and this actually is an example of one of those compromises. One of some of the discussion amongst legislators was that they felt it was important for our profession to be under the Kansas Healthcare Stabilization Fund. So we put that into our bill, but the nurse midwives and the nurse anesthetists were already in the Healthcare Stabilization Fund. So it would add nurse practitioners and clinical nurse specialists. And we are all in agreement with that. And it also, our bill started out as that all APRNs would purchase or have liability insurance. And then it was further delineated to include the Kansas Healthcare Stabilization Fund.
Thank you, ma'am, and thank you, Madam Chair.
Thank you. Representative Woodard, I think Because, no, you've got a good question. It's just going to be a little bit lengthy. So if you would take and present your question to Dave Long, my assistant, who's operating remote, and then we'll disperse it out to these folks and get an answer back, because I think it's a good one.
That sounds great, Madam Chair. Thank you.
Thank you. Representing Arnberger, and that'll be our last person today.
Thank you, Madam Chair. And my question is actually a request for research. It was mentioned that 23 other states already have this, some type of a bill into law, and I'm just curious if research could maybe break down what exactly each state has so we can have it in front of us, if it is just a different on hours or if they have something completely different for if we ever do work this bill.
Did you get that, Arida?
Madam Chair, thank you, I did.
All right, thank you. All right, committee, this will close the hearing on House Bill, what's my number? 2256. I've had too many bill numbers in my head today to remember. On House Bill 2256, and we are adjourned until tomorrow at 1:30.